Let me start by introducing you. Dr. Alopi Patel, for our viewers, is a double board certified anesthesiologist and interventional pain physician. She studied at Rutgers Medical School in New Jersey and now works at Mount Sinai West in Morningside. As a minority woman in the medical field, Alopi, you advocate for female patients who seek women physicians and you're known to go the extra mile to ensure they feel well cared for. We need more doctors like you. Both certified in lifestyle medicine, you also encourage lifestyle modifications to treat chronic pain. I think I need your number so that I can do a sidebar with you to talk to you about my chronic pain. Your podcast, Hurt by the Female Pain Docs, is meant to empower and educate patients on topics dealing with anesthesiology, pain medicine, and lifestyle medicine. You're actively engaged in clinical research projects and lecture in regional and national conferences. So we're really lucky to have you. I know we had to cancel the session last time because you had an emergency patient, but here we are. And so welcome, Alopi.
Thank you so much for having me and for your kind words. I'm really excited for this conversation.
Tell me, are you born and raised in the US or did you come from India?
So I was technically born in the United States, but I grew up in India for the first 3 years, and I came back when I was around like 3.5 years old.
Okay, so how did you choose your specialty?
So I am anesthesiology trained, and within anesthesia, we can have a few different specialties: cardiac anesthesia, regional anesthesia, pain, ICU, and whatnot. And on my pain rotation, I initially went into my pain rotation as a resident thinking that I'm going to go into cardiac and, do all the cool lines and procedures and whatnot. But after going into pain medicine, I had a few women patients actually that really hit home. And I saw that these are women that are not just women patients, but they're mothers, their daughters, their sisters. And I related with them a bit differently than other patients. And that's when I decided that I wanted to go into pain medicine.
And what does it entail when you talk about pain medicine?
So pain medicine is a field that focuses on interventions such as injections, stimulators, and whatnot, as well as medications. And in my practice, and I think a lot of different physicians are adapting to this approach, but including like holistic approaches, lifestyle modifications, nutrition counseling, sleep counseling, and whatnot. So having a very comprehensive approach to pain medicine.
Okay, so tell me, can you provide an overview of endometriosis, for example, and its symptoms?
So endometriosis is actually a very, unfortunately, common condition. Well, common in the sense that it affects about 10% of the population. But it is possibly even higher than that. It's very underdiagnosed. Endometriosis is basically a condition where the lining of the uterus, the endometrium, can be found in other places of the body. So instead of the endometrium being in the uterus, it can grow in other parts of the body, whether it's outside of the uterus, in the cervix, or on other organs even. And it can be quite painful because just like hormones can cause natural changes in the uterus lining, they can cause natural changes of that tissue elsewhere. So it can grow and get smaller, and cause pain depending on where in the body it is.
And how common is it amongst women to have endometriosis?
So that's a great question. Depending on the studies, you'll see about 10%, but really a lot of people are saying that number might be even higher. There's a significant delay to being diagnosed with endometriosis. I believe women, some of the statistics say that women on average see at least 6 or 7 physicians before being diagnosed. And it can take up to 7 years to actually be accurately diagnosed with endometriosis.
That is incredible. So they can be suffering in pain for such a long time and it can't be diagnosed. I wanted to ask you in particular whether South Asian women suffer more or less. Is there any cultural thing about people who suffer from endometriosis?
So culturally speaking, I don't think there's a difference in the number in terms of that 10% or more. But in terms of the stigma and the cultural barriers and access to healthcare, I think there definitely is. I think oftentimes there is a lot of cultural barriers and stigma around pain with sex, dyspareunia, or painful sex basically. And endometriosis patients often have painful sex. So the stigma of speaking up about having pain with sex or even premarital sex can really hinder patients from seeing physicians.
So my co-founder Medha has joined in, and she has a question for you. I'm going to just admit her and let her into this so she can talk to you about her particular question. So Medha, if you want to accept the invite.
Hi, Medha.
Hi, how are you?
I'm well, how are you? Can you hear me okay?
Good, and I'm very excited about talking to you today because I have very severe endometriosis. And so I have a two-part question, and I've talked a lot with Monika about this over time and also with people on our podcast. So I have endometriosis, and there are times when my pain is absolutely debilitating. You know, I'm just completely knocked out. And based on experience, I've now learned to listen to my body. But sometimes I feel like I'm judged by certain people around me, often men, who think that I'm lazy in the moment, or, you know, I don't have the stamina to do something. So what would you recommend for those who often have to balance listening to their bodies versus...
I think we've lost you, Medha, but maybe Alopi, you can start answering the question until.
So what Medha is experiencing is unfortunately very common for many women who experience endometriosis pain. They are often dismissed. Their symptoms are not taken seriously, right? So it really plays into the fact that this is why it takes so long to be diagnosed. Hi, Medha.
Hi.
So I was just saying that because of this stigma, it's one of the reasons that endometriosis takes so long to be diagnosed, because women's symptoms are often dismissed. The appropriate imaging may not be done. The appropriate referrals to get diagnosed may not be done. So it's really difficult to really have to advocate for yourself. And that is something that I have seen, especially in the pelvic pain world and specifically with endometriosis. Each person's body is different. Each person's pain is different. And just like you have experienced, one of the most empowering things that a patient can do is to really advocate and seek the professionals that listen to them, that value their opinion. And I believe you probably experienced some form of medical gaslighting, perhaps even in terms of people who may not know what you're going through and then therefore dismissing it.
Even from doctors themselves.
Yep.
At well-known institutes in LA.
Yeah.
Wow. And my second question is, based on experience, I've realized that diet and exercise help. And I'm wondering if you have any recommendations and resources, communities, anything where, you know, South Asian women or women of various ethnic backgrounds can gather to talk about this and say, hey, this has been working for me, that's been working for me.
That's a great question, and social media has been very powerful for all types of conditions, including endometriosis. So, and there are also specific Facebook groups. I think oftentimes, depending on the Facebook group, there are multiple ones, but you have to find which one kind of fits the vibe, I guess, right? Because there are some that are very like medication heavy or surgery heavy or just nothing at all. So whatever it may be, I think finding the right group of people who can advocate for you as well and point you to the right resources. Social media in particular is also great. Doing hashtag researches, like searches basically, and finding communities through that as well.
Thank you.
Thanks a lot, Alopi, for answering Medha's questions.
Absolutely.
So I was wondering, you know, when it comes to South Asian women, how do they treat pain differently? Do they ignore pelvic health and sexual-induced pain? Is there a cultural aspect to these kind of sensitive topics that they will not even ask about it and they will just like pretend like ostrich in the sand mentality?
Absolutely. It's definitely a stigma. There is a barrier. Patients are less likely to ask questions, to seek help, because oftentimes women are told they are the problem, right? Just drink some wine, just relax, everything is fine. You know, you're doing something wrong. That's why you're having pain. So that that victim shaming, essentially, mentality of you're having this because of something you did, doesn't encourage people to seek healthcare for this problem. There are also lack of education, lack of resources, basically, especially in India in particular, compared to South Asian women in America versus South Asian women in India. There might be a lack of education, lack of sex ed, lack of understanding about the options that are available. Women who have access to doctors even. So even doctors, women in America can seek doctors and have the healthcare insurance and the ability to be able to seek those physicians to get help. Whereas in India, there might be more cultural stigma to finding a gynecologist who can see them for pain with sex. And I want to mention that this is in particular for premarital sex. So there's obviously a lot of cultural stigma associated in our culture with premarital sex. So women who are experiencing symptoms of painful sex, whether that's for vaginismus, which is a big sort of diagnosis in terms of painful sex, cause of painful sex, but having premarital sex can really discourage patients to seek that care because of the stigma associated with it.
I mean, I do believe that this whole premarital sex is changing, especially in urban areas in India. But on the whole, how would you as a doctor encourage people with these cultural opinions about, we can't talk about this? How do you seek them out? How do you spread the word that, this is something that you need to talk about, and, how do the patients come to you?
Social media, for one. I think Mira and I are both very active on social media, and we speak about it. I think in the beginning, for me personally, it was a shell that I had to break as a South Asian woman growing up in a cultural household, right? That I had to break that shell to be able to speak about it freely for my patients and for the sake of my patients. So speaking about it openly on social media, having more women such as yourself, giving other women platforms to be able to amplify that message, right? And I think Indian women are doing an amazing job having these platforms, speaking openly, speaking freely. And I think even certain, I actually just read about this the other day, but like certain media and movie industry. So even the marketing in India for like condoms is changing, right? So the perception of sex ed is changing in cultures, which I think is really helpful. And even Bollywood, there was a movie called Oh My God that came out many years ago. And I don't follow Bollywood movies as much as I used to, but now there's a sequel to that coming out that focuses on sex ed, basically something that is not really taught or talked about openly, right? But now there's a Bollywood movie coming out about it. So again, it creates conversation. It creates awareness to people who their only source of information might be social media, might be, watching movies or TV shows or whatever it may be.
Tell me, suppose for people listening, they may have family, a sister, a mother, or somebody who has it. What is the most common way that people might say, oh, let me ask the doctor to check for endometriosis? If, like you say, it sometimes takes 7 years to diagnose, what are the things they should be looking out for? And related, but not quite related, suppose, women are having sex. If you have endometriosis, does it prevent you from having an orgasm? And is that one of the symptoms?
Not necessarily. So endometriosis can vary in terms of severity. The primary imaging usually can start with an MRI or an ultrasound, but really the gold standard for diagnosis is surgery. So it's called a diagnostic laparoscopy. A small camera is placed in the abdomen to take a look at if there are endometriosis lesions. So it really depends on the severity of the lesions. That being said, orgasm doesn't necessarily, having endometriosis does not necessarily prohibit you from having an orgasm. So sexual desire, sexual function is a very multifaceted psychological as well as physiological and anatomical combination. So orgasm, depending again on where the lesions are, does not need to be prohibited necessarily.
And where these lesions are, of course, you can't see them because it's in an area, and probably you need, like you said, imaging. Is it that it's so painful that unbearable, which is why people would go to a doctor? Like, it's not just pop a Tylenol and you'll be okay.
Absolutely. It can be so painful that it can be debilitating and prevent functionality and orgasm. and whatnot, but it depends on where and how much it is. But yes, pain can definitely play a role in that. And menstrual cramps are basically, actually there's been more evidence looking at this, that menstrual cramps are actually quite powerful. And we as women often just work through it, live through it. And endometriosis pain can often get worse with menstruation. And that pain can be even worse than what we usually would experience for menstrual cramps. So it can be quite debilitating.
So people like Medha, you know, educated, living in the West, understand and they're aware, and, you know, hers was diagnosed. I'm just thinking to myself, in these rare cases where it takes 7 years to diagnose, they live with that pain thinking it's just menstrual cramps or something like that, and hot water bag, or, you know, or...
Absolutely. Absolutely. It also depends on, you know, where in the world you are, yes, but, you know, what treatment options are available in that area, what imaging options are available. But oftentimes, endometriosis is not like the first diagnosis that people jump to. It's often ruling out other things, right? And the most common, as they say in medicine, look for the horse, not the zebra. Horses are more common diagnoses, zebras are more rare diagnoses. So what are more common diagnoses? Menstrual cramps, you know, just even vaginismus is quite rare, but basically advocating for things or looking for things that are more common rather than really looking at the more uncommon ones like vaginismus and endometriosis.
I stand corrected. Medha just says it took me 20 years to get diagnosed. So, and somebody else has mentioned, my sister-in-law suffers from adenomyosis. How different is it from endometriosis? She suffers every month, sometimes passing out with the pain. What treatments are available for it?
So adenomyosis is very similar to endometriosis. It's similar sort of lesions, but they're within the uterus. So again, different from fibroids, different from endometriosis, but the lesions are in the actual uterus. And again, they can expand and shrink over time with hormones and whatnot. And that too can be quite painful. And again, it's a very visceral sort of feeling. So one of the ways I try to explain it to patients is the kind of being kicked in your stomach sort of feeling. When somebody kicks you in the stomach, it's that takes your breath away sort of feeling. Oftentimes it's very visceral when patients have this, especially during menstruation, basically.
And what treatments are available for it, adenomyosis?
For adenomyosis, again, it comes down to medications and surgery and whatnot, very similar. The definitive really way of treating endometriosis and adenomyosis, unfortunately, is hysterectomy. Hysterectomy is not an option for everyone, right? So hysterectomy basically means we take the entire uterus out because that's where the tissue is coming from. So let's take the entire uterus out. But for childbearing age women, that's not necessarily an option.
Exactly, yeah.
And that actually brings me to a side story, but the word hysteria. Do you know the origin of hysteria, right? So this is something that's been popular on social media, but the origin for hysteria or hysterectomy and whatnot, right? So hysteria comes from the Greek word hystera, which is the uterus. So, you know, a long time ago when mostly scientists and whatnot were men, they used to attribute the uterus to all the problems.
Yeah.
So if something was wrong, we take the uterus out, we focus on the uterus, but often it was not the uterus that was the problem. It was true other medical conditions like epilepsy or, you know, other nerve conditions and whatnot. But the uterus would be taken out, a hysterectomy would be done because they just assumed that removing the uterus was the solution.
What an interesting story. Somebody else is just saying, I didn't get my endometriosis diagnosed for 30 years. So that 7-year thing, which I was shocked at, now we're hearing 20 and we're hearing 30, and to live with that forever. Tell me, Alopi, what other kinds of female pain is there other than endometriosis, adenomyosis, and things like that?
Absolutely. So vulvodynia is another common medical condition I see in my practice. Vulvodynia is pain in the vulva, and that can be for many different causes: infection, inflammatory, skin conditions, and whatnot. So vulvodynia meaning pain around the vulva. There can be vaginismus, so I kind of alluded to that before. Vaginismus is literally the closing of the muscles around the vagina, and it can cause really painful pain with insertion of dilators, tampons, pain with sex and whatnot. So those are two common ones I see in my practice. We can also see interstitial cystitis, which is now known as painful bladder syndrome or bladder pain syndrome. That is when there can be inflammation basically of the bladder and a constant feeling of like pelvic fullness, again, urinary urgency, pelvic pain. Those are some of the more common ones that I see, but also things like IBD, inflammatory bowel disease, inflammatory bowel symptoms and syndrome and whatnot. So having that chronic abdominal fullness, pelvic floor muscle dysfunction associated with that.
Just before I continue, go with my next question, the adenomyosis woman is saying thank you, and the other lady is saying thank you. This is a great chat. I had horrible pain every month and I would vomit, and it really helps to know that she's not alone in this. So this is such an important topic for women to talk about, and it is something that is just so underspoken, you know, and just hidden and put under. What I wanted to ask you is, other than say like laparoscopy or surgery, are there creams and things that women can use to help them?
Absolutely, absolutely. So depending on the type of pain that the person is experiencing, and I'll tell you my spiel as I tell my patients, but in general, when there's pelvic pain, the pelvic pain can be from muscles, nerves, bone, or tissue. So tissue is some of the stuff that we talked about, right? Endometriosis, fibroids, adenomyosis. Bone-related pain would be like tailbone pain, sacroiliac joint pain, and then you have muscle and nerve pain. So nerve pain can be something like pinching of the pudendal nerve, causing irritation into that, like stabbing pain into the vagina. And then muscle pain is like tight hypertonic pelvic muscles that can cause pain just from that area, from any insertion or even urination or defecation and whatnot. So that's like the wide sort of reasons that people can have the pain. So depending on what type of pain that they're having, we can suggest certain types of medication. So for example, the primary is almost always lifestyle modifications, right? So the primary treatment is usually if there's constipation and straining associated with constipation that's making the pain worse, how can we supplement fiber and hydration to help avoid constipation and straining to make the pelvic pain worse? So lifestyle modifications are the first line of treatment, and then come physical therapy. So this includes internal physical therapy, either via the rectum or the vagina, different types of massages, breathing exercises to help focus on those muscles, right? And then come the medications. Now medications can come in as a compound cream, like you mentioned, or we can prescribe them as a suppository, or we can prescribe them orally. So for pelvic pain, compound creams are a good option for something like vulvodynia, which is that pain around the vulva. So if this is something that is pain from superficial penetration, so pain from contact of the penis or a dilator or a tampon or whatever it may be, perhaps a compound cream like lidocaine cream might be good. If this is perimenopausal sort of irritation, or then we might perhaps prescribe something like estrogen, vaginal estrogen, which has also been quite popular on social media. Almost every woman who is of menopause and after should be on some sort of vaginal estrogen, assuming there are no other risk factors associated with it. But vaginal estrogen is really important to the pliability, the health of the vaginal and the vulvar tissue, right? So vaginal estrogen is a compound cream essentially. If there is an aspect of pudendal nerve pain or irritation around a certain area, perhaps this patient had an episiotomy or cutting part of that area for childbirth, then maybe they have very pinpoint area of pain or numbness or stabbing. So perhaps we might prescribe something like ketamine, which is a nerve sort of medication, amitriptyline nerve medication, compound cream around that area. So compound cream is a great way to really localize where the pain is and apply medication there. Suppositories we can prescribe vaginally or rectally. And usually these are things like muscle relaxants, baclofen, Valium, which is diazepam. These are medications that can be inserted vaginally or rectally to help relax some of those muscles. And then we get to oral medications. So oral medications are abundant in terms of whether we want to focus on the muscles, the nerve, and whatnot.
I have another question from someone. Can someone with Lynch syndrome use vaginal estrogen?
I would believe so, but I would advise you to talk to your doctor. And I'm assuming they're talking about the Lynch syndrome that's, more GI related. So again, they would have to speak to their doctor to make sure. Most women are eligible to use vaginal estrogen, especially perimenopausal and beyond. But again, this is something that I would refer to their doctor.
Right. Okay. Talking about doctors and healthcare professionals, do you think South Asian women are treated equitably by healthcare professionals? During COVID, there was this whole thing about women of color not being treated equitably. And how can one address potential biases like this?
So I think that's a very multifaceted answer. I think it definitely varies based on location, right? So location geographically, what part of the country. I think in New York, you're more likely to have better access to care, better diversity and whatnot. So you're more likely to have that. But that being said, in other parts of the country, if there's less diversity, they're more likely to face cultural barriers, cultural stigma associated with that. And then two, I think it also depends on the gender of the physicians. There's been a lot of studies based on that dyad, right? The physician-patient dyad, whether it's male-female, female-female, and whatnot. That partnership, basically, of physician and patient, can also contribute to feeling unheard, experiencing microaggressions, stigma, and whatnot. So I think the long answer is that, and the short answer is yes, there are health inequalities.
And how do you address these potential biases?
How do I address these? So for me, again, social media. I'm quite the advocate to speak up about this on social media, to talk to friends, to colleagues, to advocate for my patients, but also empower my patients to ask questions, to speak up, to get that second opinion, third opinion if they have any questions or concerns, to do their research. I think an empowered patient should always ask questions. It should not always be, this is it, and this is how you have to do it. I think being able to ask questions and have a physician be able to focus on the problem without taking away from their problem.
As a minority woman yourself and as a doctor, have you ever faced any kind of discrimination or bias in your profession or, growing up?
Absolutely. Absolutely. I mean, I was a I still am obviously a minority, but I think, growing up in a town where I was definitely a minority, and it seemed so too. I faced microaggressions. I faced hurdles that I hope my children don't have to face, right? So I used to go to school in my salwar kameez because my grandparents would dress me, right? So having that salwar kameez, having the oil in my hair, the braid, I've experienced it all, right? Growing up in America and not knowing that this is something that kids get made fun of, and then experiencing some of that discrimination. It made me very hypervigilant to other people's differences in a good way, that we should be more tolerant, that everybody comes from a different background. And that's why America is the melting pot, right? Being accepting of other people's differences. So I think I definitely have experienced those discrimination and inequalities, but I think the world has changed a lot, and I think we're continuing to change. I think we have a long way to go still, even in healthcare.
Talking about healthcare, what is the most important thing for women to look out for when it just comes to managing their genital pain? And any advice to women in general, and they see women in particular, about taking care of their health?
So, in terms of what to look out for, I think feeling heard, right? So when you go to a physician or a healthcare professional, whatever it may be, make sure you're feeling heard, that you are asking questions and receiving the answers appropriately and not being dismissed and getting that time, right? And in terms of what advice I would say advocate for yourself. So like I said, do your research, ask questions, bring an ally, a sibling or a parent or a friend or whatever it may be to advocate for yourself as well. But really believe in your pain and believe that you will find the right person to help treat it. And I tell my patients too that, I will tell you to the best of my ability what I think I can do to help you, but if you still want to get a second opinion, I will help you find somebody else to get that second opinion or third opinion from, because patients should feel heard and validated.
Do you find that as a South Asian doctor, a lot more South Asian women want to come to you because they feel a comfort value?
I will say I do have a decent amount of South Asian patients, and it's because that shared cultural understanding, right? So vaginismus is something that I see a lot of my South Asian women face, and I see it in my practice, and it's oftentimes associated with that stigma of sex, right? Not talking about it, having that psychological anxiety over sex and whatnot. And vaginismus is a multifaceted diagnosis. So I have a lot of South Asian women, yes, who do seek out other South Asian physicians. I too, myself, personally, I feel like I connect well with South Asian women, and some of my physicians are also South Asian women. So I think having that shared culture is often a good way to connect.
Just last couple of questions. Are these diseases, I guess you can call them diseases, are they genetic, or can they be inherited? If your mother has it, your grandmother has it, that you would be prone to it? And is there anything you can do to prevent getting it?
So that's a great question. So depending on the medical condition, so for example, endometriosis, absolutely, there is a genetic component to it. For things like vaginismus, perhaps not. Vaginismus is psychological as well as anatomical and physiological to a certain degree. So something like vaginismus might not be genetic. In terms of how to prevent pelvic pain, I wish I had an answer for that, but I think rather than prevention, it's more of a preparation, I guess is a better way, right? So having that understanding of before engaging in sexual activity, that education, asking questions, the ability to ask physicians the questions that would really help make a difference. So it's more about preparation, I think, for the medical conditions, for the treatments and whatnot, rather than prevention, because it is hard to prevent pelvic pain. It can happen for any reason at all.
And how about vaginal health in terms of hygiene and keeping it clean? Words of advice, before or after sex, or during periods, or how regularly you change your pads and tampons and things like that?
So for pelvic health and vaginal hygiene, so for vaginal hygiene, we always say don't put any soaps or any douches, detergents, anything like that. A normal, healthy vulva, basically that area around the vaginal opening, should just be basically rinsed as regular with just water. It doesn't need any other special attention in terms of scrubbing or detergents or soaps or anything like that. In fact, it can change the balance of the pH in there and make patients more prone to infections, including yeast infections and whatnot. So that would be good vaginal hygiene. So less is more for vaginal health. In terms of how often to change tampons and whatnot, so definitely don't keep it in for longer than a day for sure. Tampons should be changed regularly. I don't have an exact time for how often, but do not keep it in for too long, because there are instances where it can cause full body infection, like really bad toxic shock syndrome. So they should be changed pretty regularly. Pads, again, regularly. I wouldn't be able to give you an exact time, but every few hours and whatnot. And obviously they depend on the type of tampon, type of pads. But these are great questions that I'm sure many people don't know the answer to. I've heard of like young women who didn't know they had to change their tampon every few hours or day, and they would go the entire period with one tampon, right? And this is how things like toxic shock syndrome happen. So toxic shock syndrome is when bacteria basically can accumulate on it and then cause a blood infection, basically sepsis from that. So I think these are very important questions that we often take for granted that we know the answer to, but without sex ed and without education in general, it's hard for people to know.
Thank you so much, Alopi. This has been such an eye-opening conversation. I'm sure a lot of our viewers who've been listening have taken back a lot of value from this conversation. Any last words of advice?
Last words of advice. I always believe in asking questions. So ask questions, feel heard, and make sure you understand and agree with what is going on in your medical decision making. I really do believe in patient empowerment, and I advocate for my patients, and I encourage my patients to advocate for themselves as well.
And you can be found on the Female Pain Docs on Instagram, and you have a podcast.
We do. It's called The Hurt by the Female Pain Docs, and it can be found on Spotify, Apple, many different platforms. And actually, our most recent episode was on medical gaslighting, meaning how to advocate for yourself in the healthcare landscape and to feel heard and get the appropriate medical treatment.
Thank you, Alopi. Thank you so much. And to all our listeners, our next live session is next week, 7th of August. We're going to be talking to Sangeeta Pillai of Soul Sutras, and we will have answers to all your sex-related questions in that podcast. So do tune in again. Thank you so much.
My pleasure. Thank you for having me.
Bye.
Bye.